Welcome back, everyone. I am absolutely thrilled you're here today. We are exploring the fascinating, high-stakes world of surgical decision-making and operating room physics in this brand new explainer. We're going to peel back the layers of a safe surgery, and we're looking far beyond just the scalpel to understand the microscopic materials and the invisible physics that literally dictate whether an operation is a success or a failure.
So here's our roadmap for today. First, the science of sutures. Second, abdominal wound closure. Third, vascular and intestinal repair. And finally, operating room hazards.
Right, let's jump right into Section 1. The science of sutures, our microscopic building blocks.
You know, the fundamental choice of thread a surgeon selects can completely determine the outcome of an entire operation. Take braided, multifilament sutures versus monofilament sutures, for example. Think of a braided suture kind of like a microscopic rope. Because it's woven together, it has these interstitial gaps, basically tiny spaces where bacteria can actually hide from our body's immune cells. On the flip side, monofilaments are a lot like fishing line. They're smooth, single strands that offer incredibly high infection resistance, mostly because the bacteria simply have nowhere to hide. And that is exactly why monofilaments are the go-to choice in contaminated tissue fields.
Yeah, every single material we put into the human body is going to evoke an inflammatory immune response. But the differences between these materials are staggering. At the very top of the tissue reaction scale, surgical steel and metal staplers are the absolute champions. They evoke a minimal reaction and offer the highest resistance to infection. Then we've got synthetics like polypropylene, which trigger a low reaction. But look down at the bottom of the scale. Natural biological materials like braided silk or linen, they cause a high and sometimes even severe inflammatory reaction as the body aggressively tries to break them down.
Speaking of breaking down, the decay curve for a very common absorbable suture known as polygalactin 910, or Vicryl, is super predictable. It's fantastic for a lot of uses, but its tensile strength drops off a cliff long before the actual physical thread is absorbed. At just 2 weeks, it's already down to 60% strength. By 3 weeks, a mere 30% remains. So while complete absorption takes roughly 60 to 90 days, you can clearly see why a surgeon would never use Vicryl in tissues that are under prolonged structural stress. It just isn't going to hold the line.
But contrast that with synthetic, non-absorbable sutures like polypropylene. These maintain their tensile strength indefinitely within living tissue, greater than 1 year and beyond. They don't undergo that enzymatic degradation, and they don't lose mass over time. So unlike biological silk that fragments and weakens over a few months, these synthetics provide a totally permanent structural anchor.
Okay, moving on to Section 2. Abdominal wound closure. Sealing the core.
So applying these microscopic principles to a massive macro challenge, like sealing the core of the abdomen, is absolutely crucial. And a patient's history actively dictates the material we use. For a standard closure, we want a delayed absorbable monofilament like polydioxanone, or PDS. This allows for a gradual load transfer. As the suture slowly weakens over weeks, the healing fascia takes on more and more of the structural burden. But if we're dealing with a complex patient who's had multiple previous operations or has a high risk of poor healing, we completely shift strategies. We use a non-absorbable monofilament like polypropylene. Why? Because that fascia might never fully regain its independent strength, so it's going to require permanent mechanical support.
And this perfectly illustrates what happens when surgical technique totally ignores the physics of tissue tension. We call it the cheese wire effect, and it's as visceral as it sounds. Historically, surgeons took traditional large bites, about 1 full centimeter from the wound edge, to close the abdomen. But doing that places massive focal tension on the tissue. It causes the suture to literally tear through the muscle like a wire through cheese, leading to disastrous incisional hernias. Today, we know better. A continuous closure using small half-centimeter bites with a smaller needle evenly distributes that tension and dramatically lowers hernia risk.
All right, let's shift gears to Section 3, vascular and intestinal repair, high-stakes anatomy.
When we move into the delicate, high-stakes anatomy of vascular and intestinal repair, a single leak is catastrophic. So the rules here are incredibly strict. First up, you absolutely must use a synthetic monofilament. Remember those braided ropes we talked about? They cause a drag effect that activates platelets and forms an obstructing blood clot. No good. Second, and this is a really critical maneuver, the needle has to be passed from the inside of the vessel to the outside on the downstream edge. You have to tack down that delicate inner lining, the intima. If you go outside to in, you risk pushing that layer down and creating a flap that blocks blood flow completely. Finally, because these smooth synthetics have such low friction and high structural memory, you've got to secure them with 6 to 8 throws of a reef knot. Otherwise, they'll slip right open.
Now, the intestines have their own fascinating historical evolution. Lombard pioneered a single-layer technique that inverted the tissue, but honestly, it just lacked strength. Sen and Kocher tried a double-layer approach, but that bulky method caused tissue ischemia, which is a lack of blood flow, and it actually constricted the bowel lumen. Ultimately, Halsted and Matheson perfected the single-layer extramucosal technique, which is firmly recognized today as the modern gold standard. And the reason Halsted and Matheson's technique is the gold standard, it all comes down to this incredible anatomical secret. The submucosa is the strongest holding layer of the entire gut. Their extramucosal technique succeeds so brilliantly because it precisely incorporates this ultra-strong submucosal layer for mechanical strength, while safely avoiding the innermost mucosal layer. That prevents any narrowing or choking of the intestine. It's incredibly elegant.
Finally, let's zoom out for Section 4. Operating room hazards, the invisible physics.
So stepping back from the patient's anatomy to look at the room itself, I want you to think about this for a second. When a patient is entirely asleep under general anesthesia, completely, perfectly still, what peripheral nerve do you think is most commonly damaged without a scalpel ever even touching it?
Well, if you guess the ulnar nerve, you hit the nail on the head. It happens in about 0.33% of cases. Because the ulnar nerve runs superficially right behind the elbow, just simple, improper positioning on the hard operating table can compress it. This pressure causes ischemia of the tiny blood vessels feeding the nerve, resulting in injury. And there are other hidden hazards too. The radial nerve can hit the table's rigid edge, the brachial plexus can be dangerously stretched if the arm is extended past 90 degrees, and the common peroneal nerve can easily get crushed against metal stirrup bars. In the OR, positioning is literally a matter of safety.
This concept of invisible danger perfectly transitions into the literal physics of the room, specifically surgical diathermy, the electrical tools used to cut tissue and stop bleeding. Standard commercial electricity runs at 50 to 60 Hz, which causes dangerous neuromuscular depolarization, electrocution, essentially. But surgical diathermy uses ultra-high frequencies, anywhere from 400 kHz to 10 MHz. These frequencies are so incredibly fast that they bypass that neuromuscular depolarization entirely. Instead, they convert electrical energy directly into localized thermal energy.
And the way we manipulate that energy is just mind-blowing. When a surgeon uses cutting mode, the tool emits a continuous sinusoidal wave at a lower voltage. This creates such rapid, intense heat that the water inside the cells instantly vaporizes. It causes a microscopic cellular explosion that slices seamlessly through tissue. But switch over to coagulation mode, and the tool emits an intermittent burst wave at a higher voltage. This slower heating method denatures proteins and dehydrates the cells, effectively causing a local thrombosis to stop the bleeding. It is pure applied physics right at the tip of a blade.
But as you can imagine, playing with high-frequency electricity carries a steep risk. Which brings us to one final, pivotal question for you. What do you think is the most common complication or injury associated with using these electrosurgical tools?
It's accidental thermal burns. And the mechanism goes right back to the dispersive pad principle. For this tool to work, the electrical current has to travel through the patient's body and safely exit through a large patient return electrode. We call it the dispersive pad. The physics dictate that heat generation is inversely proportional to surface area. So we need a huge surface area on that pad to lower the electrical resistance so the current exits safely. But if that pad partially detaches during surgery, the contact surface area drastically shrinks. The local electrical resistance skyrockets, and extreme localized heat is generated right where the pad is failing.
Which leaves us with this incredible, somewhat terrifying realization: the most common electrosurgical injury isn't from the surgeon's blade itself, but a hidden burn from an improperly attached pad somewhere else on the body. It just goes to show that mastering surgery isn't only about knowing where to cut or what thread to sew with, it's about respecting the deep, unseen physics of the environment. So next time you think of a modern hospital, ask yourself, what other invisible forces are quietly determining the line between a routine procedure and a catastrophic failure? Thanks for exploring this with me.